Hey everyone, welcome back to The Explainer. If you've been following along with us, you know we're systematically breaking down the, let's be honest, kind of complex world of medical coding. Well, today we're diving right into part 4. We're talking diagnostic radiology and musculoskeletal or MSK imaging coding. Look, whether you're a coder, an auditor, or a healthcare pro, getting these rules down cold is absolutely non-negotiable if you want clean claim submissions. So we're going to break down the exact guidelines, the modifiers, and the real-world clinical scenarios that you absolutely need to know.
Okay, so here's our roadmap for today's session. Section 1 is joint basics and arthrography. Then Section 2, conventional X-ray coding rules. Section 3 covers computed tomography or CT coding. Section 4 is all about magnetic resonance imaging, MRI. Section 5, ultrasound coding guidelines. And finally, Section 6 will wrap it up with contrast rules and a clinical summary. Let's get right to it.
All right, Section 1, joint basics and arthrography. Let's start by bridging the gap between clinical anatomy and coding. Whenever a provider actually orders imaging, they're trying to evaluate the very specific structures of a healthy joint. Just think about it. You've got the articular cartilage that cushions the bone ends, the articular capsule wrapping the whole joint up tight, and that joint cavity holding the synovial fluid. Radiologists are constantly looking at these specific synovial components to spot any degeneration, tearing, or inflammation. It's kind of like looking under the hood of a car to find the exact part that's wearing down.
And that actually brings us to a super common clinical indication. You're going to see this repeatedly across imaging orders, joint effusion. Now, in your documentation, you might also spot the fancier synonym, hydroarthrosis. Basically, this is an abnormal buildup of excess fluid right inside that joint capsule we were just talking about. It's what patients usually mean when they complain about having water on the joint. Recognizing this specific diagnosis is totally key, right? Because it's what justifies the medical necessity for a lot of the imaging modalities we're about to cover.
Now, check this out. This is arthrography. What's really interesting here is that contrast is injected directly into the joint space before they even take the images. It's a highly detailed procedure that lets providers evaluate internal joint structures so much more clearly than a standard plain film ever could. It literally lets the radiologist see exactly where the contrast flows, or more importantly, where it leaks.
So when you're coding for arthrography, there are a few really strict rules to keep in mind. First off, these CPT codes live in the radiology section, and they actually bundle the radiological supervision and interpretation, the S&I. You're going to find them categorized broadly by upper and lower extremity. And why do providers order this? Usually it's for suspected rotator cuff tears, maybe a glenoid or acetabular labral tear, or just that persistent unexplained joint pain that standard imaging completely missed.
Moving right along to Section 2, conventional X-ray coding rules. Now, on a standard conventional radiograph, unlike arthrography, the coding is highly anatomically specific. You can't just broadly search for upper extremity. You need to look specifically for the shoulder, the elbow, or the wrist. And for the lower limbs, you're looking for the hip, knee, or ankle. Pinpointing that exact anatomical site is always your very first sorting mechanism when you open up that CPT manual. Here is the absolute crucial point, though. Once you've nailed down that anatomical site, it's the view counts that dictates your final code selection. Was it 2 views, 3 views, a minimum of 4 views? The medical documentation has to state this explicitly. And honestly, laterality modifiers are completely mandatory here if you want a clean claim. You literally must append RT for right, LT for left, or modifier 50 if it was a bilateral procedure. No exceptions. Well, okay, beware of this one big trap. Here's a strict rulebook call-out for you. If the CPT code descriptor itself explicitly includes the word bilateral, you absolutely do not assign modifier 50. If you do, that's double billing, and we definitely want to avoid that. Also, keep the infant rule in the back of your mind. Because infants are, so tiny, an entire limb might actually fit onto a single imaging cassette. If that entire infant limb is captured in one single study, you do not report multiple individual joint codes, just the one.
Let's put on our senior auditor hats and walk through this sample medical report. The clinical history mentions an injury with lateral wrist pain. Then, look at the findings. 3+ views left wrist, no acute fracture or dislocation. Because we have the exact site, the wrist, the specific view count of 3 views, and the left laterality, we can confidently assign CPT 73110 with the LT modifier. It is exactly that kind of direct one-to-one translation from documentation to code that ensures your compliance is rock solid.
All right, up next is Section 3, Computed Tomography, or CT coding.
So when we look at a CT scan, like a transaxial scan of the knee, for instance, the rules shift a bit. Unlike X-rays, CT codes are not specific to the individual joint. Instead, they're classified broadly by upper or lower extremity. Once you make that upper or lower choice, the codes are then subdivided based exclusively on contrast utilization. That means you're choosing between without contrast, with contrast, or without followed by with contrast.
Now, here is a critical rule that catches a ton of coders off guard: the route of administration. If contrast is given intravenously or intra-articularly, meaning right into the joint, it meets the strict guidelines for a with contrast CT code. However, oral or rectal contrast is strictly coded as a without contrast study. Why? Because that route only really outlines the bowel. It doesn't highlight the MSK structures we're actually trying to evaluate here.
Let's dissect another report, this time for a CT. The exam type header says CT lower extremity without contrast, RT, for a knee injury. In the findings section, the radiologist explicitly writes, examination without intravenous contrast. This makes our job so easy. It perfectly guides our code choice. We just look under CT lower extremity, select the without contrast code, and slap on that RT modifier for the right knee. Simple, right? No guessing required at all.
Let's keep the momentum going with Section 4, Magnetic Resonance Imaging, or MRI.
When you're coding MRIs of the extremities, your very first step is figuring out if you're using a joint or non-joint code. The clinical indications are usually a dead giveaway for this. Providers tend to order joint MRIs mainly for sports injury evaluations, ligamentous disruptions, think ACL or PCL tears, meniscal tears, and occult stress fractures that the standard X-rays completely missed. Basically, if the focus is on the joint space and its supporting soft tissue, you're firmly in the joint code family.
So how does this look in practice? Let's analyze this MRI report. The history notes pain, an inability to ambulate, and a negative X-ray. The technique clearly states MR knee without con LT, using a non-contrast standard protocol. And the findings mention an intact medial meniscus, but with mild intrasubstantial degeneration. Since it's a knee, we grab the MRI lower extremity joint code. Since the technique specifically says non-contrast, we choose the without contrast option. And finally, we just append the LT modifier for the left side. Boom. Done.
Moving on to Section 5, Ultrasound or USG Coding Guidelines.
Diagnostic ultrasound is super cool because it's so dynamic. With the ultrasound probe placed directly on the joint, the provider gets this excellent real-time visualization. It's fantastic for spotting joint effusions, synovitis, bursitis, and even peripheral nerve entrapments like carpal tunnel syndrome. But here's the thing, the real challenge for you as a coder isn't the anatomy. It's actually figuring out the true scope of the evaluation.
You really have to weigh the strict documentation requirements that separate a complete study from a limited study. For a complete study, that's CPT 76881, the documentation requires a real-time evaluation of both the joint space and the surrounding periarticular soft tissue. If the radiologist only evaluates the joint space, or maybe just a single anatomic structure, you absolutely must downcode that to the limited study, which is CPT 76882. And keep in mind, both of these codes are unilateral by default, so you're going to need that modifier 50 if the study was done bilaterally. Which brings us to our final section, Section 6, Contrast Rules and Clinical Summary.
Now, on top of the CPT codes we've just covered, you also have to capture the specific contrast agents used, and you do that via HCPCS codes. For example, arthrography often uses water-soluble iodine, which you'd code as S0259. CT scans usually use agents like IsoView, which fall into the Q9966 range. And MRIs? They rely heavily on gadolinium-based agents, coded from A9575 to A9585. So, just to summarize everything we've tackled today, you always want to count your views for X-rays, strictly verify the route of contrast for CTs and MRIs, check for complete versus limited documentation in ultrasounds, and whatever you do, never forget those laterality modifiers.
And that officially wraps up our deep dive into diagnostic MSK radiology coding. So, what does this all mean for you? Well, are you potentially leaving revenue on the table by misinterpreting contrast routes or maybe missing bilateral modifiers? I challenge you to review your last 10 claims and find out. If you found this explainer helpful for your day-to-day practice, make sure you like, share, subscribe to Decode Healthcare with Harshal. Join us in Part 5, where we're going to pivot and talk all about therapeutic procedures and joint injections. Keep learning, and I'll catch you in the next explainer.